Hi everyone who's just come into the Zoom. Today we've got Cam Cheema, he's an ST6, works with us at Lewisham and Greenwich. He'll be covering spinal traumas in a very interactive way. So we'll pass over to him to get on with the chat.
Perfect, thank you, Emma. So my name is Cam, as Emma has already mentioned. I'm an orthopaedic registrar based at Woolwich and Lewisham, and today I'll be covering the topic of spinal trauma. As you can imagine, spinal trauma is a really extensive topic, lots and lots of presentations, but today we'll just be dipping our toe into spinal trauma and spinal cord injury, and hopefully we'll be able to look at x-rays and CT scans and determine what level the injuries are at and have a safe way of assessing the patients. So next page. So objectives, as like I said earlier, how to assess patients who are presenting with spinal trauma as part of an ATLS team. And I think you've had a talk already on the advanced trauma life support principles, and we'll talk about some of the spinal precautions during this talk as well. How to assess radiographs, as that's incredibly important, especially if you're on call. Spinal cord injuries and how to manage those and how to assess those. And Cauda equina syndrome, which is a common medical school topic. So spinal cord trauma. About 15,000 permanent spinal cord injuries present per year in the UK. Males more than females, potentially because we do more stupid things. And the mechanisms are usually high energy. The body's made in such a way that the spinal cord is quite deeply embedded at the dorsal aspect of your body to try and prevent injury to the spine. However, with high energy, such as road traffic incidents, falls from height, or penetrating trauma, which is rare, you can cause a spinal cord injury. In the UK, we use something called the BOAST guidelines, the British Orthopaedic Association Standards of Trauma. I'd really suggest that you log online, have a look for these standards for managing patients with spinal cord injury. As long as you stick to this protocol, you won't be too far off the best practice, okay? And always remember your ATLS principles and working within a team. So, if someone has come in to A&E, into the resus area, and a trauma call has been put out, and there's any mention of high energy or spinal injury, they should be triple immobilized. And what does triple immobilization mean? And if you look at this individual over here in the photo, I don't know this person. The triple immobilization includes the collar, which is a hard collar here, applied just underneath his chin and onto his sternum. This should be measured, but I won't go into how to measure this, as this is something you should be taught face-to-face in person on how to measure a collar and apply it safely. And sometimes actually two individuals applying it is better than one. The blocks, which are at both sides of his head to prevent rotation, and tape. The tape should be fixed to a non-movable part of the bed. So the hard metal bits on either side of the bed would be sufficient. And this is the gold standard. If you have triple immobilized the patient, and documented that triple immobilization has taken place, you are safe and you've given the patient the gold standard treatment for his C-spine. Always, always have a low threshold to suspect someone has a spinal cord injury. They may be intoxicated, they may have a distracting injury. You can imagine if they've got an open femur fracture, they may not be able to tell you that their neck's hurting. So please be aware and have a low threshold. If there's any doubt whatsoever, triple immobilize, have the patient on a spinal board. Next, when it comes to examination, usually the whole spine should be examined all the way from the head, all the way down to the coccyx. To do this safely and to prevent any rotational force to the spine, this should be done as per a log roll, where you need 4 individuals to carefully maneuver the patient so you can palpate the back all the way from head to coccyx to see whether there's any pinpoint tenderness or any bruising. There should also be an in-depth dermatomal and myotomal assessment. And remember, this is part of the secondary survey. Don't do this when someone else is assessing the airway. This comes later. This is not a life-threatening injury, although it could be later down the line, but the airway is likely to kill him first. So please do this as part of the secondary survey. And the ASIA chart we will talk about, okay? So here's the ASIA chart. So this is from the American Spinal Association. And this is the gold standard for examining a patient's dermatomes, myotomes, and also even being able to tell whether this is an incomplete or a complete spinal cord injury. The reason I mention this chart is reproducible, is easily accessible online, and it can be followed on a day-to-day basis to see how the spinal cord injury progresses. And it's very, very detailed. And if you do forget dermatomes or myotomes, they are clearly labeled on this side. Well, the only ones I would ask you to remember, if you haven't got access to an ASIA chart, is the nipples are at T4, T10 is the umbilicus, L1 is like a diaper, L3 over the knee, okay? And then you can work the rest out thereafter, okay? And remember, C7 is to the middle finger, and therefore you can work out C6 is the thumb, and C8 is the little finger. If you can't find this chart, or you can't remember your dermatomes and myotomes, just remember only these few ones and you can work the rest out. And by in-depth dermatomal examination, you must do light touch, you must do pinprick, and you must tick all these boxes to make sure you're safe and you don't miss any injury. As part of this, there's also myotomal examination, and you can see this on the motor side here. Just in case you forget, this is a very accessible document online. Even use it to revise for your med student exams, because this is really, really important. And always, always remember to do anal tone. There must be a PR that is documented, okay? And that's how we tell whether this is a complete or incomplete injury. And I'll come on to that a bit later, okay? So please look at this. So scanning. So a patient comes in, you're worried that there is a spinal cord injury, or you're worried there's a spinal fracture. Most of these patients already have high velocity trauma. They've fallen from 15 meters from a ladder, or they've been hit in a road traffic incident, and you will be doing a CT trauma series. So if you are scanning the head, it makes sense to also scan the neck at the same time. And the British Orthopaedic Association standards recommend very thin slices, 2 to 3 millimeters. Most higher level CTs now will do 0.625 millimeter slices. So this should be at least this standard. The BOSE guidelines do mention, however, after T1, you could actually do X-rays, plain radiographs, AP and laterals of the thoracic spine and the lumbar spine. However, if the patient's in a CT scan already, and they're probably going to have their abdomen scanned and their chest scanned at the same time as part of the trauma series, why not just do a CT off the whole spine at the same time? Always remember, don't rely on just CT. CT looks at bones. There may be spinal cord injury, which will only be picked up on an MRI or clinical examination alone. Don't rely on radiology, rely on your clinical examination, and always document. So we're going to talk about lateral C-spine radiographs. I think this is an important starting point, because even if you were to look at CT scans later down the line, I would still use these same principles for examining a spine. So this is a lateral radiograph of someone's C-spine. First of all, you need to make sure it's an adequate view. And by adequate view, you need to be able to see the C7-T1 junction. How do we know where that is? So if I want you to look really, really closely, I'm going to zoom in as well. This vertebrae here is the odontoid peg. You can see it looks very different to the other vertebrae, and hence why it's called a peg. This is C2. If that's C2, this must be C3, C4, C5, C6, C7, and you can see the T1 vertebrae, and you can see the junction here. So this would be an adequate radiograph, okay? How do we look at this in more detail? How do we have a system to look through this? And these are the lines of the C-spine. This is called the prevertebral line. It should be nice, smooth, and congruent, going across the anterior aspect of all the vertebral bodies, okay? Posterior vertebral line, once again, nice, smooth, and congruent on the posterior aspect of all the vertebral bodies. This is called the spinolaminar line. And in between lies the spinal cord. And at the back, there's an extra line, which is the spinous process line. But however, it can be a bit mismatched at the C-spine, but it's a more congruent further down the spine. Always remember soft tissues. These may be well lined up because you've got the patient immobilized in triple immobilization, and there may not be an obvious fracture, or there may not be an obvious deformity. Look at the soft tissue. This is a soft tissue line here. You're allowed up to 1/3 vertebral width of soft tissue shadow up to C5, and thereafter you're allowed 1 vertebral width. So please always look at this, the soft tissue shadows. That this may be a telltale sign that there's an occult injury which is not picked up on a plain radiograph. If you can't have an adequate X-ray, you can't see the C7-T1 junction, get a CT scan. Don't fiddle around with swimmer's views or any other views. Get a CT scan. Now, the AP C-spine radiograph, I always struggled to look at these, but what I want you to really look at is this is the vertebral body here, and to the sides here, you start seeing what looks like eyes here. These eyes are the pedicles, okay? And to the side, you see superior and inferior articular facets, and you can see the articulations in between, okay? And in between, you can see the tracheal shadow. And always remember, you've got access to the superior part of the hemithoraces here. Make sure you rule out a pneumothorax as well. So once again, vertebral bodies, pedicles, articular facets, okay? And always remember, right at the top here, once again, the odontoid peg sitting between the lateral masses of the ATLS C1. Make sure there's symmetry here as well. Fine. I'm not sure if any of you have used Mentimeter before, but please follow the instructions at the top. Go to menti.com, whether that's on your laptop, open a new window, or use your phone. Use this code and you'll have access to this. And what I really want to, before I ask you to vote on this, I'm just going to go back to this slide here. And always remember, the odontoid peg is C2. This must be C3. So if there was an injury at this level here, this will be the C2, C3 junction, okay? So C2, C3, this will be the junction. Now, let's go to my question, okay? What level is the injury? Don't all rush in at once. Okay, one response, 2, okay. Any others? I'll give you a minute to respond.
Yeah, I think people are probably logging in.
Yeah, I'll give them a minute for this first time. I'll give you another 30 seconds if anyone else wants to vote. Fantastic. I think that's enough time for this question. So pretty unanimous. The majority going for C5, C6, and I think I will agree with them. Let's just double check. So once again, this is C2. You can see the odontoid peg. Always use this as your landmark. Therefore, above must be C1. This is C2. C3, 4, 5. This is C6. You can see this traumatic spondylolisthesis at the level of C5, C6. I can see more people are jumping in with C5, C6 now as the answer. Fine. So traumatic spondylolisthesis. And once again, if we were to use our method that we're using before, you'd be able to pick this up pretty easily. You'd be following your anterior vertebral line. You'd see disruption. Posterior vertebral line, disruption. Spinolaminar line, disruption. And it's pretty obvious anyway. Okay, so well done to everyone who answered C5, C6. Next one. So once again, what level is the injury? There's an arrow pointing to it. I'll give it a minute in total. 7 responses so far. 10 responses. $17 responses. Okay, I think that's enough time. So once again, let's go through this in a systematic manner. C2, this is your benchmark. This is where you start, okay? It's the easiest one to identify. C2, 3, 4, 5. Here's a superior end plate fracture of C5. So well done to the majority who answered C5. Fine, let's move on. So, like we mentioned, there's the odontoid peg fracture. Like I said, if I go back a slide, this is your C2, and this is the odontoid peg, okay? And I'm going to go back just a couple of slides, just to show you, on this view here, you can see the odontoid peg there, and this is the vertebral body underneath of C2. Let's go forwards now. Oops. the odontoid peg, otherwise known as C2, is commonly fractured. It's usually an osteoporotic or a fragility fracture seen in the elderly age group, although you can see it in younger patients, but it's usually high energy trauma. The treatment, once again, depends on the fracture location. And I find this classification very, very useful. And it's the Anderson and DeLonzo classification. Type 1 is a fracture which is at the tip. There are some cruciform ligaments which attach to the tip, and this is an avulsion fracture. It's very stable and has a good chance of healing, okay? C2 is the waist. This is a bit more worrisome. This has a watershed area blood supply. And what I mean by that, the tip has its own blood supply. The vertebral body has its own blood supply, but this is kind of in the middle. It doesn't really have a blood supply from the top, and it doesn't really have it from the bottom. It's just sharing. This is the watershed area. And there's a high chance of non-union at the type 2. Type 3, into the vertebral body, big, wide metaphyseal bone, lots of blood supply here, and this one heals very well, okay? And this is why this classification is quite useful, as it will guide your management. Once again, let's look through this together in more detail. I'm going to look in a bit closer as well. Your C2 vertebrae here. And if you follow it along, you see the tip of the odontoid peg has gone backwards. It is dorsally angulated, and you can see the opening of the fracture anteriorly, okay? So this person, if the immediate amount of energy to cause this fracture hasn't caused paralysis or death, they will probably be coming in holding their head, or they'll be on a spinal board, okay, coming into A&E. Always make sure you look at the swimmer's view. And this is just to show why 2 views are so important, because this is dorsally angulated and it hasn't translated medially or laterally. You can't actually see it on this radiograph, okay? Make sure you identify the peg, you look at the vertebral body, and you see the lateral masses either side. And the distance between the lateral masses and the odontoid peg should be symmetrical. There are reasons for asymmetry, rheumatoid arthritis, etc., but generally, the distance should be symmetrical between the peg and the lateral masses. Also look at the lateral edges of the lateral masses. They should line up with the edge of the C2 vertebra, okay? And if this is hanging off the side, you're worried about a C1 fracture. And this is called an open mouth view. So commonly they'll present with neck pain. They may be actually even holding their head when they come into A&E because their neck feels unstable. They can have dysphagia or breathing difficulties because the C2 is right at the back of your mouth. And this is how obvious it is. This is an open mouth view, and the odontoid peg is right at the back of the mouth. So there's no doubt that they get dysphagia. They can have reduced sensation or motor power or even paralysis because the level of injury is very, very high. They can even have a significant neurogenic shock, okay? And we'll talk about neurogenic shock later. Imaging, like I said, I would always go for a CT scan. This is high energy trauma, and I would also be considering a CT trauma series, which is a CT neck, chest, abdomen, and pelvis. If you are stuck with x-rays, AP, lateral of the C-spine, open mouth odontoid peg view, okay? And the treatment is a hard collar, and they can remain in a collar for up to 12 weeks as a definitive management. For younger individuals, especially the type 2, because there is a high chance of non-union, it will be fixation or it will be a halo vest. Don't worry about those so much, okay? Now moving on to the more typical vertebrae, your T, L, and S, some of the S spine. This is the vertebral body. This is a lateral view of the vertebral body. This is the anterior aspect of the vertebral body. That's the posterior aspect of the vertebral body. Once again, you can see the articular facets pointing upwards, and the bit in between is called the lamina, okay? And here's the spinous process at the back, okay? And here you can see an articular facet from the vertebra below articulating with the vertebra below. Inferior articular facet, superior articular facet, and in between is the facet joint. In this gap here would lie your spinal cord. And Denis has come up with this 3-column theory. Generally, if one column has gone, i.e. the anterior one, is far away from the spinal cord and you're less worried. If 2 or more columns have gone, you are very, very worried. And this patient should be triple immobilized from the neck and should be on spinal precautions, which means this flat spinal board and strict log rolling only, okay? So Denis, column 3, the anterior 2/3, posterior 1/3 of the vertebra is the middle column, and all the posterior elements are the posterior column. Types of vertebral fracture. Like I said, I'm not going to go into massive detail with these, as this is quite complex and quite high level, but I just want you to appreciate there are types, and we'll talk about what I think of them and how we can go about assessing them, okay? The most common is this osteopenic, osteoporotic fragility fracture, which is a compression fracture. This is affecting mostly the anterior column, and what you'll notice is the posterior part of the vertebra, the height remains normal. It's only the anterior which is compressed, and this is a wedge fracture. Low chance of having any injury to the spinal cord, and this would be a stable fracture pattern. This you worry about. This is a burst fracture. Anterior and middle column have both gone here, and part of the middle column has now retropulsed, which means it's moved posteriorly into the spinal canal, which means it may be impinging on the spinal cord. And if so, you may expect neurological signs, motor or sensory, okay? This is a worrying one. This is one that needs to be referred to neurosurgeons or a spinal orthopedic center very, very quickly. I want you to just be aware of this translation rotation. Is a type of a rotational injury, which is very, very rare. And you will see the vertebra above is translated anteriorly. The facet joint has decided to dislocate, and both facet joints must have dislocated for this to move anteriorly. And when the energy's gone through, it's caused a wedge fracture of the vertebra below, okay? And once again, these are the ones that are commonly missed. It's a distraction injury. You can even have a wedge fracture anteriorly associated with this, but the posterior elements distract and become wider. And you can imagine the middle column is affected. This can lead to spinal cord injury as well. So please be mindful of this. Always look at all levels of the spinal cord, and we'll go through some of the examples of this shortly. So once again, these are lateral radiographs of the spine. I'm not going to go through how to describe radiographs because I think you've done that already. But once again, we're going to look for a place to start. And the place to start is this one here. This obviously is a sacrum. This must be L5, the last lumbar vertebra. This is the one you should always start with. So once again, like we used the system earlier, looking at anterior vertebral line, something quite not right here, is there, in the anterior column? Go through your posterior vertebral line, and what you'll see is the height here of the middle column is remained, and the posterior elements, the distance between these the spinous processes remains the same. So once again, L5, 4, 3, 2, 1. This is an L1 anterior wedge fracture. The middle column height is preserved, and the posterior element distance is preserved. So this is a stable fracture pattern at L5, 4, 3, 2, L1, okay? I'm going to ignore this one in the middle on purpose. And what I want you to look at is this one here now. This is your flexion distraction type injury. And look at these distances between the spinous processes here. It's much narrower compared to this one here. And that's because the interspinous ligaments at the back have stretched, which means there must also be a fracture of the middle column as well. This is the one to worry about, and this is the one that people miss, because they only ever look at the front. They're too frightened to look at the back. We're going to ignore this one here because this is coming up. Feel free to vote. Fantastic. I think that's enough votes for the moment. Pretty unanimous. I think I'm doing a good job of teaching you how to read these radiographs. So this is actually a sagittal CT scan of the lumbar spine. But like always, the X-rays are the starting, how you start to learn how to read CT scans. And once again, this is the sacrum. So this must be L5. This is what we start with. 4, 3, 2, 1, T12. And if you look very, very closely, anterior column is narrowed compared to the other. So the height of the anterior column is reduced. There's a fracture of the back. So the middle column is gone. And on here, we can't really appreciate the posterior elements because it's one slice of a sagittal CT scan. But what you can see here is there is at least 2 columns gone here. And this fragment here, which is coming from the superior end plate, has actually retropulsed into the spinal canal. This is someone you're very worried about. It's an unstable fracture pattern with a retropulsed fragment into the spinal canal. This is where the ASIA chart is incredibly important to make sure that there's documented motor and sensory function and whether this is a complete or incomplete spinal cord injury, which we'll talk about. So this is dangerous. Moving on. So this is something that comes up more in medical school exams, comes up in postgraduate exams, and we rarely see in the hospital. I've probably seen central cord syndrome maybe 5 times in my life. It's incredibly rare, but it's something that you need to be aware of. So just an overview of an axial cut of the spinal cord, okay? I just want you to be aware of the rough locations of where things are, okay? Dorsal columns are at the back, because they're dorsal, okay? Cortical spinal tracts at the side, and there's 2, there's lateral and there's anterior, okay? And what I also want you to be aware of is we've done the corticospinal, we've done the spinothalamic, and we've done the dorsal columns. That's all you need to be aware of, sorry. So going on to central cord syndrome. So once again, seen in the elderly population, it's an hyperextension injury to the C-spine, and often can be associated with an osteophyte fracture, which causes contusion to the spinal cord at that level, okay? And the typical signs are you get motor loss. The upper limbs are more affected than the low limbs, and we'll talk why that is. And the sensation can be variable, and sometimes the sensation is not affected at all, okay? Why are the upper limbs affected more than the low limbs, okay? And remember, this is a motor loss. The motor is the corticospinal tract. It goes from the cortex of the brain to the spine. That's the way I remember it. It's going from top to bottom, okay? Most of the fibers which supply the upper limb decussate in the most central part of the corticospinal tract. So there's no wonder the upper limbs are more affected than the lower limbs, as the lower limbs are more out to the side. It's the upper limbs which decussate in the middle, okay? Anterior cord syndrome, never seen it in my life, but once again, they love asking in medical school. Don't ask me why. Hyperflexion injury, okay, affects the front of the spinal cord, and you can see your lateral corticospinal tract is very close to this anterior aspect, okay? And this can lead to spinal shock and paralysis because the anterior spinal artery is very nearby, okay? This is often associated with death. Often these patients don't make it into hospital. Moving on, Brown's acquired, never seen it in my life, but yet once again, love asking it in medical school. Hemisection of a cord. I think the only ways you can really get a hemisection of a cord is a penetrating injury, which is rare. And you can imagine if you only hemisect half of the cord, you're going to get damage to the dorsal columns at the back. So let's just start on this side. Let's just say this side's been affected. You get problems with the dorsal columns at the back. So deep touch, proprioception, and vibration will be lost. Okay. You get a lower motor neuron injury at the same level, upper motor neuron below, and you'll lose contralateral pain and temperature. The reason being the lateral spinothalamic tract decussates at the same level. So it moves over to the other side. So once again, hemisection of cord from a penetrating injury, fine touch and proprioception lost on the ipsilateral side due to the dorsal columns, pain and temperature on the contralateral side as these decussate at the same level. And you can also lose light touch on the ipsilateral side as well, okay? Posterior cord syndrome is not traumatic, and it's often associated with neurological conditions such as MS and myasthenia gravis. It's not an orthopedic problem. Refer to medics. So, spinal shock versus neurogenic shock, a very important principle to know the difference between, this is something I used to get confused at when I was at medical school as well, because the science can be very, very similar, okay? And what I want you to remember is spinal shock is only a transient problem. And this is associated with trauma, which leads to a contusion or edema of the spinal cord. And the changes are transient, so they can recover or they change. And this typically can last up to a period of 48 hours. So if there's a change after 48 hours, you know this is spinal shock without even worrying about any of the other signs or symptoms, okay? With both of them, you can get hypertension. Both of them, you can get bradycardia, which makes it very confusing. We'll talk about the bulbar cavernosus reflex shortly. And this motor can be flaccid on this side because the spine is shocked. We don't go into upper motor neuron straight away. Usually it starts with flaccid paralysis. It can be variable neurogenic shock, okay? And typically 48 hours, spinal shock gets better, okay? And once again, neurogenic shock, there's an injury to the sympathetic nervous system, which is usually higher up, usually in the C-spine, which leads to this massive autonomic drop. You lose the peripheral vasculature all dilates because all the sympathetic nerves acting on capillaries and arterioles and all that stuff dilate. You get massive hypertension. Your C3, 4, 5, C4, 3, 4, 5 for the heart becomes injured. So you get bradycardia, and the bulbar cavernosus reflex can be variable. And we'll talk about that as well, okay? When is spinal shock over? So this is how you tell the difference. And we was talking about it on the ASIA chart earlier, when you can tell the difference between an incomplete and a complete spinal cord injury. When it's incomplete, your bulbar cavernosus reflex is not there. What is a bulbar cavernosus reflex? Because I've mentioned it a few times. So typically, if you're looking at textbooks, the bulbar cavernosus reflex is looking for an anal wink when squeezing the glans penis, or squeezing the clitoris and looking for an anal wink. This is something that you're not really going to be doing in modern medicine. This is not acceptable to do, okay? So please don't start doing this. What I would suggest you do is use a catheter, because that's also important to monitor a person when they're in spinal shock, because like I said, they can be hypertensive and bradycardia, and often they will need fluid resuscitation, okay? So insert a catheter tug, or looking for an anal wink will tell you if the bulbar cavernosus reflex is present. If it has returned, that means the spinal cord injury is now complete. They have now left spinal shock, this transient period, and this is likely to be the end result. And this is usually after 48 hours. So that's enough on spinal cord injury. We're just dipping our toe into it, okay? Now, moving on to Cauda equina syndrome. This is more of a common A&E referral, but once again, a rare condition, but it's a surgical emergency, and it's something that you should be aware of, okay? The typical signs and symptoms that you would experience is an acute onset of sensory motor deficit, and this could be unilateral or bilateral, and it's related to acute compression of the Cauda equina. What is the Cauda equina? It's all these nerve roots leaving the spinal cord after the filum terminale, after L1. So this is the filum terminale, and this is the Cauda equina. Anything that leads to compression of this will lead to Cauda equina syndrome. So the back pain, typically, although symptoms and presentation can vary because pain is very subjective, is usually 10 out of 10 pain. It's extreme pain, radiculopathy, which means pain radiating down a dermatomal distribution, either uni or bilaterally. They can also have motor loss. So remember the ASIA chart. You can use that to remind yourself of how to test the myotomes of the lower limb. This is the most pathognomonic presentation, is a saddle anesthesia. They can't feel the perineum. They can't feel themselves sat on a chair. This is a very important question to ask. And they'll often have incontinence and loss of anal tone. So please, please do a PR, do the ASIA chart, document things clearly, because a missed Cauda equina, although it's a rare presentation, is a £1 million payout if it is missed, but it can lead to severe, irreversible neurological deficit. So causes of Cauda equina syndrome. So the way I like to think of it is things that can happen inside the spinal canal and things that can happen outside. We'll start with the outside because these are more common. Herniated disc is the single most common. It can be due to trauma, which is unlikely because remember, this is well protected, it's deep, it's dorsal. Usually trauma doesn't travel all the way back here. We usually take trauma head on. It's very rare for trauma to hit you from behind, okay? And even then it's deeply protected. Tumors, so these could be bony or soft tissue, and these could be, a sarcoma in the muscle. This could be a lipoma. It could be many, many different types of tumors. And also remember discitis. The disc is outside the canal. And if you get a discitis which forms an epidural abscess, it can press on the spinal cord as well. Inside the spinal canal, once again, very, very rare. Epidural spinal anesthesia, they are infiltrating anesthetic into the spinal canal. And if there's a large amount of pressure in the area, it can cause Cauda equina syndrome. Well, like we mentioned, epidural abscess, when a discitis or introduced via a spinal anesthesia causes an abscess in the canal. Spinal tumors, soft tissue tumors such as schwannomas, astrocytomas, gliomas, I'm sure there's many other omas, and spinal stenosis. This is rare, but if there's hypertrophy of the ligamentum flavum and there is a narrowing of the spinal canal, then that can lead to spinal stenosis as well. So once again, this is an MRI. It's a sagittal MRI. It's a T2 weighted MRI because the water is white and the spinal cord is in water. So this is very obvious. You can see the intervertebral discs in between these big blocks of vertebra, okay? So like we said, we're going to go to our L5, which is here. And if you go between L5 and S1, you'll notice the disc has protruded backwards and it's impinging on the spinal cord. And the spinal cord is nice and white because it's a T2 weighted MRI. And you see a sharp cutoff here. And so this is an L5 S1 disc which is herniated, leading to Cauda equina. Remember, Cauda equina, although there are signs on an MRI scan, i.e. this looks like Cauda equina, but it's a clinical diagnosis. Don't rely on MRI scans to rule in or rule out your Cauda equina. It's a clinical diagnosis, okay? So this is a very large L5 S1 disc causing Cauda equina syndrome, the most common presentation, okay? So like I said earlier, please make sure there's a full neurological examination is documented on an ASIA chart, because if there's anything missing there, or you've missed a Cauda equina due to an inadequate examination, you will be liable, and it is a big, big payout. Don't take the risk, okay? Make sure you check anal tone, so a PR, okay? So the anal tone is a bipolar phenomenon, okay? It's either on or is off because it's autonomic, okay? There either is anal tone or there is an anal tone. So please document one or the other. Don't put things in the notes like reduced anal tone. These things don't exist, okay? And it just annoys people. Bladder scan. This is really important. So you can imagine, to start with, the bladder is incontinent. So that will tell you that this is the patient's in this first stage, if we go all the way back, or spinal shock, okay? Because there's a temporary loss and they have flaccid paralysis. So they have a flaccid bladder, so they can get incontinence to start with, okay? And this is a really good prognostic indicator because you know they are still in an incomplete spinal injury. You can still do something about it to improve their outcome. However, if you do a bladder scan and you find 500 mils of urine still inside the bladder, they've now gone into retention, and they go into retention because their bladder is now spastic, is no longer flaccid. And if you have a residual volume, that means they're actually in complete spinal cord injury. And that's a really poor prognostic indicator. They should still obviously be treated as an emergency. They should still be referred to someone who can deal with Cauda equina. But this is a really poor prognostic indicator that they likely have completed their injury, and there's not much resolution after this stage. Management. First of all, if you're a junior, please tell a senior immediately, I'm worried about Cauda equina syndrome, so they can, get an MRI scan quickly and refer to a neurosurgeon. There are British Association of Spinal Surgeons, BAS, which recommend an urgent decompression. Timing for surgery, don't listen to stuff which says 24 hours, 48 hours. It is as soon as possible. This is like a myocardial infarction, that every minute matters, okay? Treat this like a myocardial infarction, okay? Urgent MRI scan immediately. Discuss with neurosurgeons, blue light transfer if necessary. Immediate decompression. This is an MI of the spine. And that is it. Any questions?